All right, welcome and thanks for joining us tonight. I'm going to share my screen here and we are going to get started with tonight's practice questions. So for tonight's practice questions, we are going to be covering airway and respiratory. And real quick, let me jump back over. All right. So we're going to be covering airway and respiratory practice questions at the paramedic level. And really the goal with this is to help students understand how to break down test questions when it comes to this particular topic. So, obviously with the National Registry exam, there's several major categories with airway and respiratory, cardiology, trauma, medical, and EMS operations. And tonight we're going to start with airway and respiratory, maybe potentially down the road. If there's a big enough ask and a big enough desire for it, we'll move to cardiology and so forth. But what we're going to do tonight, and if you have the ability to join us through our Slido presentation, that's fantastic. If you don't, or if you don't feel comfortable doing that, that's completely fine as well. But this is going to be a way for you to be able to kind of interact with us live, to be able so that we can see what your answers are to the questions. And then as we can see how the group does with the questions, we can further break down the test question and help point out some key topics as we move through. So one thing I do want to point out as I'm sharing my screen and I'm sharing the practice questions and the Slido screen that you see here, I don't have the ability to see the YouTube chat. So I want to bring that to your attention now. So if you put something in the chat, I'm not going to be able to see it. Because I'm sharing my screen. However, let me make sure that that's the case. Yep, that is going to be the case. So I won't be able to moderate the chat, but we will be able to accomplish the overall goal. So I'm going to spend about 1 hour on here tonight. We'll get through as many questions as we possibly can. If you don't have the ability to join the quiz via Slido, that's completely fine. You can scan the QR code that you see on the screen there and join. It doesn't require a download or anything on your end. All you have to do is scan the QR code, enter your information, and then you can kind of play along as we go through and look at the different practice questions. So I'm going to move forward and start looking at the practice questions. You can join at any time by going to slido.com and entering that number there, 2554-800. Or you can scan the QR code to join us at any time. So each practice question does have a 30-second timer on it. For the most part, I'll probably allow those 30 seconds to expire before we move on. That way, whether you're watching this live or whether you're watching this as a recording, you have the ability to really sit and digest a question, okay? So a patient with COPD is on home oxygen at 6 liters per minute via nasal cannula and presents with dyspnea and an oxygen saturation of 80%. He is conscious, but he's only able to speak 2 words at a time. What is the best initial oxygen therapy for this patient? I'm going to give you a few seconds there to read that question again and to select which answer you feel is most appropriate. And feel free to do this in your head, or feel free to scan the QR code and join the Slido quiz if you're watching us live. All right. So the correct answer for this would be CPAP at 5 to 10 centimeters of water pressure. And I might catch a little slack for that in the comments, and that's fine. But really, what I want to drive home here is we have a patient with COPD on home oxygen at 6 liters per minute via nasal cannula. So he's maxed out on a regular nasal cannula, and he's presenting with dyspnea. Remember, that's difficulty breathing, and an oxygen saturation of 80%. So he's on 6 liters a minute of oxygen via nasal cannula, and his oxygen saturation is still only 80%. He's conscious, but he's only able to speak 2 words at a time. What is the best initial oxygen therapy for this patient? So picture this patient in your head, and with any National Registry question, what I want you to do, even if it's 1 sentence long, I want you to read the question twice. So even if it's 1 sentence long, I want you to read the question twice because there's valuable information in there. And there's probably information that you're going to miss as you skim through because your nerves are going to be high and you're going to be anxious. And reading the question twice, whether you're reading it to get more information, if nothing else, it'll buy you time and help calm your nerves. Okay. So this patient's struggling to breathe. He's in respiratory distress, trending towards respiratory failure, 6 liters a minute, nasal cannula. He's having difficulty breathing. He is still conscious, which is good, but he's only able to speak with 2 words at a time. So CPAP at 5 to 10 centimeters of water pressure, I said, would be the most correct answer. And again, I'm acknowledging that I might 15 liters, but this is the way that I view this question. So we have a patient that is certainly in respiratory distress and he's heading towards respiratory failure. I have a very narrow window of opportunity at this point to try to keep this patient from becoming unresponsive and from buying an endotracheal tube, right? Or a supraglottic airway or whatever that may be for your agency. So I am going to go ahead and put this patient on CPAP. He's still a candidate. He's still conscious. He's struggling to breathe. I'm going to do my best to coach this patient so that I can put him on CPAP at 5 to 10 centimeters of water pressure. My concern is if I go to a non-rebreather mask at 15 liters a minute, although I'm giving him a higher oxygen flow and a higher oxygen concentration, I don't think this guy is going to benefit from that in the short amount of time that we have before he ultimately goes into respiratory failure. So my initial oxygen therapy for this guy is actually going to be one of the most aggressive forms of oxygen therapy that we can do, outside of intubation or a supraglottic airway placement. All right, so you're treating a patient with difficulty breathing for the past 5 days. He has ascites and pedal edema. His lung sounds are clear. What do you suspect? Okay, so hopefully you read that question twice so that you could pick up on anything that you may not have gotten the first time. You're treating a patient with difficulty breathing for the past 5 days, so this is not necessarily an acute event. He has ascites, which remember is edema in the abdomen, and pedal edema, so he has fluid distally down by his ankles. His lung sounds are clear. What do you suspect? So the correct answer for this is going to be right-sided heart failure. So the patient's right side of his heart is failing. His right ventricle is not pumping blood through the pulmonary artery into the lungs to become oxygenated the way that it should. And so we have a fluid backup problem to the right side, which makes sense as to why I'm seeing ascites in this patient and pedal edema. And it also makes sense as to why his lung sounds are clear. Because my failure problem, my backup problem is on the right side of his heart. It's not affecting the lungs at this point. So I'm not going to have fluid build up in the lungs. I'm not going to have those crackle lung sounds. So this would be a right-sided heart failure issue. And if you're just joining us before I go to the next question, remember, if you're just joining us, I cannot see the YouTube chat because I'm sharing my screen. But feel free to jump on, scan the QR code, join the Slido quiz as we go along, and we will be at it for about an hour tonight. A patient has bilateral crackles, ascites, and jugular vein distension. The patient has a long history of respiratory distress. What do you suspect? Okay, so a patient has bilateral crackles. So now we are talking about a fluid problem in the lungs. Ascites, still talking about that abdominal edema and jugular vein distension. The patient has a long history of respiratory distress. What do you suspect? So unlike the previous question, we do have lung involvement now. So I have signs and symptoms of both left-sided and right-sided heart failure in this patient. The signs of my left-sided heart failure specifically are the bilateral crackles. The signs of my right-sided heart failure are the ascites and the jugular vein distension. So remember, the number one cause of right-sided heart failure is and hopefully you just finished my sentence, is left-sided heart failure. So now my left ventricle fails to do its job appropriately. I start to have a backup of blood up into my left atria, to my pulmonary veins, into my lungs, where they build up with fluid. That's where my crackle lung sounds come from. And then eventually, because my left side of my heart isn't doing the job as effectively and as efficiently as it should be or as it can be, my right side is ultimately going to start failing as well. So the way that I like to look at left and right-sided heart failure is like an assembly line, right? Picture a warehouse in your agency's jurisdiction. Wherever the breakdown on the assembly line is going to be where the backup starts, okay? So if I have a failure line ahead of me, I'm eventually going to be affected by that. And that is exactly what is happening with left-sided and right-sided heart failure. If my left side of my heart starts to fail, my right side of my heart is ultimately going to start to fail as well, which is going to present with both signs of left-sided heart failure and right-sided heart failure. So you're treating a pyretic elderly male with difficulty breathing. The patient states that it's been getting harder and harder to breathe over the past few days. He has diminished breath sounds and crackles on the right side. What do you suspect? So you're treating a pyretic elderly male with difficulty breathing. So first and foremost, we have to figure out, what does that word pyretic mean? Because that's a sneaky word that can sneak past us when we're looking at these test questions. And remember, the National Registry, they're most likely going to ask you test questions that have medical terminology in them. They may or may not say difficulty breathing. They're more likely to say dyspnea. They may or may not say fever. They're more likely to say pyrexia or pyretic. So we have to know medical terminology before we go in and sit down for the registry exam. So you're treating a pyretic elderly male with difficulty breathing. The patient states that it's been getting harder and harder to breathe over the past few days. He has diminished breath sounds and crackles on the right side. What do you suspect? So we have diminished breath sounds and crackles on the right side. There's no mentioning of the left side, so we're going to assume that it's fine. And I also have a patient with a fever. So anytime that I hear fever and difficulty breathing, especially when it's isolated to one side of the lungs, we should automatically think pneumonia. Now, can patients have double pneumonia or bilateral pneumonia? Absolutely, they can, right? That's a bad day. However, the National Registry is not going to trick you with that test question. So the National Registry exam itself, and this is probably going to be a controversial statement, but the National Registry exam itself is a fair exam. It is, it's not designed to trick you. They don't give you more information than you necessarily need. If they are providing you with information, it is for a reason, and it is by design. Okay. So we have an elderly male with a fever. He has diminished breath sounds and crackles on the right side. We should be thinking pneumonia. Okay, so this is a multiple answer. So there's going to be more than one correct answer. Which of the following medications would we administer to a COPD patient with extreme wheezing for its corticosteroid properties? All right, so this was a multiple answer. Which of the following medications would we administer to a COPD patient with extreme wheezing for its corticosteroid properties? So we have magnesium sulfate, we have albuterol, methylprednisolone, solumedrol, and epi. Magnesium sulfate is not a corticosteroid, right? It's a smooth muscle relaxant. Albuterol is a beta-2 agonist that helps bronchodilate and open up the smaller portions of the airway. Methylprednisolone, that is a corticosteroid, and solumedrol is a corticosteroid. And then we have epinephrine, which is a sympathomimetic. It mimics the sympathetic nervous system. So this is a little bit of a trick question because methylprednisolone is Solumedrol. That's the same medication. One's a trade name and one's a generic name. But we would use Solumedrol or methylprednisolone for its corticosteroid properties for that COPD patient with extreme wheezing. So the next step in your protocol requires magnesium sulfate administration to your adult asthmatic patient. What is the appropriate dose? 4 grams IV push, 2 grams IV push, 4 grams over 10 to 20 minutes, or 2 grams over 10 to 20 minutes. Okay, so the next step in your protocol requires magnesium sulfate administration to your adult asthmatic patient. And what is the appropriate dose? So I have 4 grams IV push, which remember is the same as IV bolus, 2 grams IV push, 4 grams over 10 to 20 minutes, or 2 grams over 10 to 20 minutes. So the correct answer here is 2 grams over 10 to 20 minutes. So an easy way that I like to remember this is we give 2 grams of magnesium per heart. Okay, and let me explain that a little bit. So for our pre-eclamptic patients or who become eclamptic, so for my eclamptic patients who ultimately have a seizure, one of our drugs in that treatment protocol is magnesium sulfate, right? And what is the dose for that eclamptic seizure patient? It's 4 grams. Well, how many hearts does that patient have? Well, baby's got 1 heart, mom has 1 heart, right? So I have 2 hearts. Each one of those hearts should get 2 grams. So I give a total of 4 grams to that patient. Okay. This patient, I just have an adult asthmatic patient. They need mag sulfate. They have 1 heart. I'm going to give them 2 grams. Now, I don't mean that literally, that based on how many hearts they have, that's how much mag sulfate they need. But it's just an easy way to remember it based on, okay, am I giving mag sulfate for this asthma problem or am I giving mag sulfate for this eclamptic seizure? Okay, so think 2 grams per heart. And the other way that I've heard that is 1 gram per lung. That's kind of another way that you can tie it in and hopefully easily remember that as you move on through test questions. We primarily administer ipratropium for its blank effects. And again, while you're answering that, if you're just joining us, because of the way I'm sharing my screen, I cannot see the chat in YouTube. Please remember that or be mindful of that. I am not ignoring you if you're sending messages. I just don't have the ability to see it. But I do encourage you to join the quiz by scanning the QR code and kind of playing along as we move forward here. What I will do is when we're approaching our 1 hour, I'll jump out of the screen and I'll look at the chat. And if there's any questions, I'll try to go back and retroactively answer those. So we primarily administer ipratropium for its blank effects. Anticholinergic is absolutely the correct answer. So that's fantastic. Sympathomimetic, that would be more of like an epinephrine, right? That mimics the sympathetic nervous system. Beta-2 agonist, that's albuterol. Parasympatholytic, that is something that blocks the parasympathetic nervous system. That would be atropine as an example. So ipratropium, yes, is an anticholinergic, and what that does is helps dry secretions so that our patients can breathe a little bit better and move oxygen a little bit better, and hopefully free up the alveoli for better gas exchange. So I did just get a message saying that you're having a hard time seeing the QR code. And bear with me here because this is the first time we've done a YouTube live. Let me see if there's a better way to do this here. So you can also join us at slido.com. So if you go to slido.com and join a session, that number is 255-4800. 255 4,800, and I will put that in the chat, and hopefully everybody can see that and jump on. All right, we will get back to it. I apologize, but I want to try to make sure that everybody has an opportunity to jump on if they so wish. Okay, so we already answered this question about ipratropium. It's an anticholinergic. Fantastic job. We primarily administer albuterol for its blank effects. Correct. Beta-2 agonist. So we kind of ruined this question because the previous question was about ipratropium and gave these same answer options, but albuterol is a beta-2 agonist. So what does that mean? It stimulates our beta-2 receptor sites. Remember, agonist means stimulates or works on, right? So beta-2, our beta-2 receptors, we have two lungs. Those beta-2 receptor sites cause bronchodilation. Okay, so that is why we give albuterol to our patients with difficulty breathing, whether it's our asthma patients or COPD patients, which is emphysema, chronic bronchitis, because we need to help open up their airways, their bronchi, their bronchioles for better volume in and out and for better gas exchange ultimately. So yes, albuterol is a beta-2 agonist. Very good job. And I also think you guys are seeing my screen a little bit differently than what I am, but it's all right. We're gonna keep moving here. We'll figure out the tech part after this. Multiple answer. So there's more than one correct answer here. You have just sedated a patient and your next protocol requires you to administer a paralytic. Which of the following is a paralytic? Okay, so we kind of got a mixture of answers here. So we have succinylcholine, ketamine, midazolam, and rocuronium. So succinylcholine is correct. Rocuronium is correct. Ketamine is actually a sedative. So here's an easy way, or kind of a mnemonic that I remember in order to keep my sedatives and my paralytics separate. So for my paralytics, we carry some really cool paralytics. Some succinylcholine, really rocuronium, cool cisaturonium, and paralytics, pancuronium. So we carry some really cool paralytics. For my sedatives, we have easy knockout meds, right? So we have etomidate, ketamine, and midazolam. So if you remember those two different phrases and those two mnemonics, those will help you kind of separate my sedatives and my paralytics in my head. So we carry some really cool paralytics: succinylcholine, rocuronium, cisaturonium, and pancuronium. And we have easy knockout meds, which is my sedatives: etomidate, ketamine, and midazolam, which is also Versed. Your paramedic partner is preparing to sedate a patient for rapid sequence intubation. He asks you to prepare the sedative for administration. Which of the following is a sedative? All right, strong work. So your paramedic partner is preparing to sedate a patient for rapid sequence intubation. He asked you to prepare the sedative for administration. Which of the following is a sedative? So my first three are paralytics, right? Some really cool paralytics: etomidate, that easy knockout meds, my etomidate, ketamine, and midazolam. So etomidate, that is the only sedative here. Great job. I'm going to show you the next question, and while you're looking at the next question, I'm going to jump out and see if I can't fix a technical issue here. So this is multiple answer, more than one right answer. Asthma primarily has two main pathologies. What are they? And it gave you a little bit more time there than what it should have, because I had to back out and fix something. And I think you guys are on the right slide now for those actually watching and not in the Slido. So multiple answer, meaning we have more than one correct answer. Asthma primarily has two main pathologies. What are they? So asthma has bronchoconstriction and it has inflammation. So not only is asthma a bronchoconstriction problem, meaning that my bronchioles get tightened, they constrict, which doesn't allow good airflow back and forth, but we also have an inflammation problem. So that is why in our protocols, most often we're treating asthma with what? We're treating it with albuterol, so a beta-2 agonist, so that I can bronchodilate and try to fix my bronchoconstriction. But I'm also giving some type of corticosteroid like Metabolic or methylprednisolone, right? Same drug, we talked about it earlier, because that steroid is going to help me decrease some of that inflammation in my asthmatics. So it's a two-stage problem. It's a bronchoconstriction problem, and it's an inflammation problem. And that methylprednisolone or Metabolic, that is why we give that kind of as that 1-2 punch with albuterol, so that we are not only addressing bronchoconstriction, but we're also addressing inflammation as well. Excess mucus production, so that's actually going to be a problem with chronic bronchitis. And I do believe we talk about chronic bronchitis a little bit, but just in case we don't get to that question tonight because of time. So remember, chronic bronchitis, that's kind of one of the two terms that we put under that COPD umbrella. Emphysema and chronic bronchitis. Chronic bronchitis is excess mucus production. And remember, you have those goblet cells that line your airway, and those goblet cells are responsible for mucus production. And in those chronic bronchitis patients, those cells are just overly stimulated and they produce tons and tons of mucus. And those are the patients that really benefit from that ipratropium and its anticholinergic effects, so that we can try to dry up some of those secretions, so the patients aren't trying to take breaths through all the thick mucus and getting air down into the alveoli to help with gas exchange. This type of shock will be the result of an untreated tension pneumothorax. And if you're just joining us on YouTube, there's information in the chat on how to join us at slido.com using number 255-4800. And if you do put something in the chat, I'm not able to see it right now, but I will circle back to it at the end of tonight when we hit about an hour. All right. So we got a mixed bag here. So we're 50-50. So this type of shock will be the result of an untreated tension pneumothorax. So we have cardiogenic answered, and we have obstructive answered. So cardiogenic shock, let's first talk about that. So cardiogenic shock is a shock that results after everything else has really been addressed, right? Cardiogenic shock is a pump problem. It's not a fluid problem. It's not a volume problem. It's not a hypovolemic problem. It is a pump problem. The heart itself isn't doing its job effectively. We get down to obstructive, and obstructive is going to be the type of shock that results with untreated tension pneumothorax. Obstructive shock occurs from an untreated tension pneumothorax by the following. So think of this. If you have a hole in your lung, as you're breathing in, that air is going into your trachea, down into your airways, and into your lungs, right? Whichever lung has a hole in it, that air is going to escape and it's going to go into your thoracic cavity or your pleural space. And eventually it's going to continue to build up and build up and build up until there's nowhere else for that air to go. And we're at maximum pressure in that pleural space and everything begins to shift or have tension on it, which is where that term comes from. So as everything starts to have tension on it, eventually what's going to happen is things are going to become obstructed. So think of those two large vessels that are responsible for bringing deoxygenated blood back to the heart. So my superior vena cava and my inferior vena cava. So eventually those two main vessels that bring deoxygenated blood back to my heart so that it can become oxygenated, they are going to become obstructed. And the way that I like to teach this in class is picture a garden hose. If you go out on your driveway and you take the faucet or you take the trigger off the end of the garden hose and you lay it out across your driveway and you turn on your faucet, it's full blast. You're pumping out as much volume as you possibly can through that garden hose. There's nothing on the end of it stopping it. Well, now picture you going and putting your foot on that garden hose and putting more and more pressure down on the hose. Well, what's going to be the result of that? So the volume coming out at the other end, the open end, is eventually going to start to decrease until I put all of my body weight on that hose, and then I have no volume coming out the other end at all. And that's a very similar pathology as what's happening in these untreated tension pneumothorax patients. Is everything's fine until it's not, because I have way too much pressure in my pleural space, and it's putting way too much tension on those vessels, bringing that deoxygenated blood back into the heart to become oxygenated again. So I have an obstructed type shock with these patients. All right, and I'm still having problems here. And I'll be honest with you, I don't know why. So apparently what you're seeing on YouTube is not the same slide that's actually showing on my end and on my screen, and I don't know why. But again, I don't want to take away from the overall learning here. But what we're going to have to do is, if you want to keep track, I apologize. If you want to see where we're at with the question and want to see the question and the results, please join at slido.com using that 255-4800. Then you'll be on the same page as we are. So again, I apologize for that. Something that we'll have to figure out here. First timer. So you're responding to a single family residence for a 27-year-old female having an anxiety attack. This has been occurring for over 30 minutes. If her ABG was to be altered, what condition would you expect? So we have respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. So we're responding to a single family residence for a 27-year-old female having an anxiety attack. When I'm treating patients with an anxiety attack, what am I primarily concerned about? I'm primarily concerned about hyperventilation. So this has been occurring for over 30 minutes. If I was to do an ABG, which not that we have that ability to do it in the field, but if I was to do an ABG and it was to be altered, what condition would I expect? So I have a patient that has been hyperventilating for over 30 minutes. So just with that alone, thinking anxiety attack, hyperventilation, this is probably going to be a respiratory type problem. Now let's think of the other kind of side effects of that. So if I'm hyperventilating, I am breathing in and exhaling too much. But what I'm also doing is I am not allowing enough time for carbon dioxide to build up in my body. So I'm getting rid of way too much carbon dioxide. I'm not holding on to enough carbon dioxide for myself. I'm giving it away too freely. So as I'm giving away excess carbon dioxide or too much carbon dioxide, that is going to create an alkalotic condition. Okay, so this will be a respiratory alkalosis. So I'm going to make up numbers here, but so let's make up what this ABG would potentially look like. So remember my pH scale, a normal is 7.35 to 7.45. A pH less than 7.35 is acidosis. A pH more than 7.45 is alkalosis. So we've kind of alluded to the fact that this is going to be a respiratory alkalosis, so we need to move that pH above 7.45. Let's call it 7.49. So now I'm going to go over to my next value of my ABGs. So now I'm going to look at the respiratory component, which is my carbon dioxide. So for carbon dioxide, think of it as this. Think of carbon dioxide just naturally as an acid. And I'm not saying that it is, but think of it as I'm holding a basket of acid. If I have too many, I become acidotic. If I don't have enough, I'm not acidic. I am alkalotic, right? And it's kind of the same thing with carbon dioxide. So if I'm giving too much carbon dioxide away, I'm not acidic or acidotic, I'm alkalotic. So I'm giving too much carbon dioxide away as I hyperventilate. So my CO2 value would not be within the normal range of 35 to 45. It wouldn't be more than 45 because I'm not holding on to too much of it. I'm giving too much away. So I would have a CO2 number that's actually less than 35. So we set our pH, our make-believe pH is 7.49. I'm going to say my CO2 value is 25. Okay, now let's go to the final component of an ABG, and that's bicarb, right? Or bicarbonate levels, which is HCO3. So a normal range for bicarbonate levels is 22 to 26. Bicarb naturally is a base. If I have more than 26 bicarb, I am very basic. I am alkalotic. If I don't have enough bicarb, if I don't have enough of this material that makes a base, and I don't have 22 or more of them, then I am acidic. Now, this is a respiratory problem, so I wouldn't expect for a test question to give me an issue with my bicarbonate levels because that is a marker of my metabolic system. Okay, so this is a respiratory alkalosis problem. My pH is going to be high. My CO2 is going to be low. So the other thing I want you to remember, because we have a few more questions about ABGs here, the other thing I want you to remember is the acronym ROME, and you may have heard of that. Respiratory opposite, metabolic equal. What does that mean? It means that when you have a respiratory-driven condition, your pH and your respiratory components, so CO2, they move in opposite directions as one another. So as my pH is up, then my CO2 is going to be down if it's a respiratory problem. I'm going to have just what I have right here, respiratory alkalosis. If I have a respiratory acidosis, my pH is going to be low, meaning it's going to be less than 7.35. And my CO2 level is going to be high, meaning it's going to be higher than 45. Those two things have an inverse relationship with one another. So respiratory opposite. Now, metabolic equal. What does that mean? If my pH moves up, so does my bicarbonate, if we're talking about a metabolic-driven problem. Okay? So if my pH is showing that I'm alkalotic, well, then my HCO3 level, my bicarbonate level is also going to be elevated. If I have some type of metabolic acidosis, which would require my pH to be below 7.35, well, then my bicarb level is also going to be below its normal range of 22 to 26. And let's say that it's 18. Okay, so respiratory opposite, metabolic equal. Remember that, and that will help you as we kind of trudge through the next few questions here. So the next question is, you are transporting a patient with the following ABG. What do you suspect? pH 7.28, carbon dioxide 45, HCO3 18. Okay, So you're transporting a patient with the following ABG. What do you suspect? The pH is 7.28. So let's stop there. Is that low, normal, or high? So remember we said a normal pH is 7.35 to 7.45. So it's definitely not normal. So when we go below 7.35, that is an acidosis problem. So right now, without even looking at CO2 and HCO3, we know we have some type of acidosis. Okay, that acidosis is going to be half of the answer. So now let's go look at my respiratory and my metabolic components to see if we can figure it out. CO2 is 45. My normal CO2 range is 35 to 45. So that is within a normal range. My HCO3 is 18. My normal HCO3 range is 22 to 26. That is certainly below the normal range of 22 to 26. So 7.28 is an acidosis problem. My bicarbonate level is also lower, right? Metabolic equal. So this would be a metabolic acidosis. My respiratory value is fine. It's high normal, but it's still within normal limits. Okay. So CO2 is 45. Now, actually, I'm not gonna. I was gonna elaborate on something, but I think I'm gonna ruin a practice question, so I'm just going to. I'll sit on it for now. I'm gonna move on to the next question. I'm gonna continue to try to figure out the tech issue because we're still having it, but I'm gonna move on. And again, if you want to follow along and see how everybody's answering, you can join us at slido.com and use that 255-4800 number. All right. So we will jump to the next question, and I'll try to troubleshoot in 30 seconds. All right. So I'm going to try to continue forward with this view, and you guys are champs for your patience here. But I'm going to try to move forward with this view because I think this will allow you guys to actually see the question in real time, and I can still see your answers over here on the right. So I'm going to have to make up that 30-second timer in my head, but that's fine. All right. So you're transporting a patient with the following ABG. What do you suspect? pH is 7.48, CO2 is 44, HCO3 is 27. So let's go to the pH. pH is 7.48. Is that normal? No, it is not. It's high. Normal 7.35 to 7.45. So my pH is high, meaning I have some type of alkalosis problem. Go to my respiratory values. CO2 is 44. Is that low, normal, or high? It is normal. It is within my 35 to 45 range. HCO3 is 27. Is that low, normal, or high? My normal range is 22 to 26. So it is a little bit elevated. Okay, so that is high. My pH is high. My metabolic component is high. So my pH is high. That is an alkalosis. I have a metabolic component here that is also elevated. So it must be a metabolic alkalosis. Very good job. So with these ABG problems, and I feel like for a lot of paramedic students, these ABG problems kind of become an arch nemesis as you move through paramedic school. You should be prepared on the National Registry to not only be able to interpret ABGs as we've seen them here on the screen and be able to say, oh, that's metabolic acidosis or respiratory alkalosis, but you also need to be able to identify, well, what could be some causes of that? So it's very likely that you get a scenario, and at the end of it, it's an ABG question, but you're not giving any values. You're just given a sign or a symptom, and you're expected to identify, well, what type of ABG problem would this patient have? So let's talk about a few of those real quick, and I'm going to back up to the previous slide. So this patient, this was a previous question that we had a pH of 7.28, CO2 of 45, and HCO3 of 18. So we already identified that this would be an acidosis because the pH is low, and we identified that it's a metabolic acidosis because my bicarbonate is also low. So I should be prepared on the National Registry exam to say, oh, yeah, based on these markers, it's a metabolic acidosis, but I should also be prepared to talk about, well, how could this patient get in this condition to begin with? So what things can cause a metabolic acidosis? So it could be an aspirin overdose. It could be sepsis. It could be diabetic ketoacidosis. It could be renal failure. Any of those things can lead this patient into a metabolic acidosis. Now, something that is very possible, and I hate to mix protocols with paramedic school and education standards because sometimes there's overlap, but a lot of times there's not. But if you are working with an agency right now, or hopefully your instructors have taught you this, it's likely that in order for you to truly diagnose or reaffirm that you have a DKA patient in front of you, or you have a sepsis patient in front of you, we look at end tidal capnography values to help determine, oh, yep, this is for sure a DKA patient, or this is for sure a sepsis patient. I never should say for sure, but high index of suspicion, right? So with this type of patient, or let's say this is a DKA patient, a diabetic ketoacidosis patient, this ABG would probably be pretty accurate, except my CO2 value. So for a DKA patient or a sepsis patient, really any type of metabolic acidosis patient, but it's just more prominent to talk about DKA and sepsis, we are actually going to see a low CO2 number. Okay, so if you see that on the National Registry exam, or you see it on a test question in the paramedic school, or you see it in an ambulance right in front of you, don't let that freak you out. So my pH is low, my bicarbonate low. So I got metabolic acidosis. Well, what in the world? My CO2 is also low, and it's not in this example, but let's play make-believe for a second and say my CO2 is 25 for this scenario. So why is my CO2 low? Because that would be an alkalosis type problem or finding, right? We've already discussed that. But my pH is low, meaning acidosis, and my bicarb is low, meaning a metabolic acidosis. So what we are finding there is that the patient's trying to compensate. So if you think about DKA, what type of respiratory pattern do our DKA patients have? Q-small respirations, right? So they have these deep, rapid respirations. And the reason they're doing that is their body's compensatory mechanism to try to get rid of CO2, because they know if they have too much CO2, they become acidotic. They're already acidotic here just from a metabolic issue, but it's the body's way of trying to figure out, well, how can I try to get this pH scale back into a normal range or close to? Well, I can try to get rid of this carbon dioxide stuff, right? Because if I dump my carbon dioxide, maybe I'll help shift the pH back to a normal range. So a lot of protocols, and again, I hate mixing protocols in paramedic school because they don't often overlap real well, or at least in your favor for the registry exam. A lot of protocols will say, is one of the indicators of sepsis, to rule in sepsis or to rule in DKA, end tidal CO2 must be applied. And waveform capnography must be at a level of around 25 or less. Usually that marker is 25. So it's just a really good indicator that, yep, this patient is in some type of metabolic alkalosis. We know that because they are, metabolic acidosis. We know that because they're septic, or we know that because they're in DKA. But their body's also trying to compensate by trying to blow off and get rid of excess CO2. It's not going to fix the sepsis. It's not going to fix the DKA. But it's the body's compensatory mechanism to try to get itself back to a more normal pH by getting rid of CO2. Okay, so keep that in mind. If you see it on the registry or a paramedic program test question of, well, what in the world? My pH, my HCO3 are aligning here. They're moving in an equal direction, but my CO2 is also low. That doesn't make sense. From a true ABG perspective, it doesn't make sense, but it's the body's way of trying to compensate for the metabolic acidosis that it's in, so that it can try to blow off CO2 and try to get that pH back to a more normal 7.35 level. All right. So for this patient, we've already answered this question. Yes, this would be a metabolic alkalosis. There's not a ton of causes of this that we talk about in paramedic school, but think If we had patients that overdose on antacids, that they ate several bottles of Tums, something like that, and that just made them incredibly alkalotic because those are antacids. They would have to eat a lot of Tums to do that, but antacid overdose is a possibility for metabolic alkalosis. Excess vomiting is as well, because we're getting rid of all the extra stomach acid that we have. And with a lot of excess vomiting, we could have a metabolic alkalosis. All right, we'll go to our next question here. So you're transporting a patient with the following ABG. What do you suspect? pH 7.32, CO2 is 54, HCO3 is 24. All right. So we're transporting a patient with the following ABG. What do we suspect? pH is 7.32. So right off the bat, is that low, normal, or high? Okay. So we said 7.35 to 7.45 is normal. So this is low. So this is going to be some type of acidosis problem. CO2 is 54. Normal is 35 to 45. So my CO2 is elevated. HCO3 is 24. Normal is 22 to 26. That is right smack dab in the middle. So I don't have a metabolic problem. I'm not concerned about my bicarbonate levels. So if I go to pH, I have an acidosis problem. CO2 is 54. Remember, respiratory opposite. My pH is going down. My CO2 is going up. So that makes sense. So I have a respiratory acidosis problem. I have too much CO2. This patient's retaining or holding on to too much carbon dioxide. They're not giving enough of it away. And that is making them become acidotic. So this is a respiratory acidosis. So just with that mechanism and just with that explanation, what's something that you think could cause a respiratory acidosis problem? They're retaining too much CO2. Well, if I'm retaining too much CO2, it's probably going to be some type of hypoventilation problem, right? The patient is not breathing enough on his or her own, or maybe we're bagging them and we're not doing a good job of assisting their ventilations or providing their ventilations entirely, or waiting way too long in between breaths. The patient needs to move more air faster. So this is a respiratory acidosis problem. They're holding on to too much CO2. We have a few minutes left, but we'll try to get through as much as we can here. So you have just applied CPAP to a 66-year-old female with a history of CHF. The PEEP setting should not exceed I think now I'm screwing you guys up in order for me to be able to see your answers, but all right. So we just applied CPAP to a 66-year-old with a history of CHF. The PEEP setting should not exceed. Very good. So 10 centimeters of water pressure. Now, you may have different protocols at your agency that say you can go above 10, but this isn't, the test isn't based on your agency's protocols, right? So generally, we talk about a PEEP setting. Remember, PEEP is positive end expiratory pressure. We talk about PEEP settings between 5 to 10 centimeters of water pressure. So we should never really exceed 10 centimeters of water pressure without medical control or medical direction allowing us to do that. The next question here, you're on the scene of a motorcycle MVA. The patient is not breathing and has an obvious deformity to his cervical spine. With this information, why do you suspect the patient is not breathing? Good. So disruption of phrenic nerve. So you're on the scene of a motorcycle MVA. The patient is not breathing and has an obvious deformity to his cervical spine. With this information, why do you suspect the patient is not breathing? So we got a motorcycle wreck. The patient's not breathing. He has an obvious deformity to his cervical spine. The question is giving us that information for a reason, right? It must be pertinent and to how I get to the answer. With that information, why do you suspect the patient is not breathing? So disruption of the phrenic nerve is correct. So a ruptured diaphragm, absolutely. Can patients have ruptured diaphragms from motorcycle wrecks? Of course. But this question really isn't giving me any information to just automatically jump to, I wonder if this is a ruptured diaphragm, right? They're giving me very specific information about this patient's one injury, at least, that he has a deformity to his cervical spine. Tension pneumothorax, there's nothing in the question that leads me to that. Upper airway obstruction, there's nothing in the question that leads me to that. Disruption of the phrenic nerve. So remember, the phrenic nerve exits somewhere between the level of C3 and C5, depending on the person. And that phrenic nerve is what's responsible for movement of the diaphragm itself. Okay, so this isn't necessarily a diaphragm issue. It's a nerve issue. This patient has some type of rupture of that phrenic nerve, and he or she does not have the ability for the brain to send signals to the diaphragm to move upward or downward to create that positive or negative pressure for us to actually take a breath in or take a breath out. So this is going to be a phrenic nerve problem. Very good. And we'll do a few more, and then I'll jump over to the chat just to make sure that I get any questions answered, as I haven't been able to look at those throughout the live session here. So you just intubated a cardiac arrest patient. Next, you need to confirm correct tube placement. What is the best method to do this? So we've just intubated a cardiac arrest patient. Next, we need to confirm correct tube placement. What is the best method to do this? Per the AHA, it's a class 1 recommendation. Waveform capnography is the gold standard for monitoring the patient's airway and confirming that we have appropriate tube placement. Auscultation of lung sounds, absolutely, it needs to happen. Condensation in the tube can be a marker that we're in the right place. Adequate rise and fall of the chest, that's a great sign to tell me that my tube is in place, and as I ventilate, I'm getting good rise and fall of the chest, but nothing beats waveform capnography, okay? So even if you have an answer selection of visualization of the tube passing through the cords, if I replace one of these answers, let's say I replace auscultation of lung sounds with visualization of the tube passing through the cords, the best method, the gold standard of confirming correct endotracheal tube placement is waveform capnography. The only place in our body that makes carbon dioxide that we're going to detect from waveform capnography is in the lungs. So if I'm detecting waveform capnography, or I'm detecting carbon dioxide through waveform capnography, I should say, then my tube has to be in the appropriate place, right? That confirms my placement. So good. All right. So I'm going to stop sharing my screen, and I'm going to jump over to the chat here. I don't see any questions. I see a very zoomed in view, which is not incredibly pleasing. So I apologize for the technology issues. I don't know why you guys weren't seeing the same screen that I was as I was moving through. Regardless, I appreciate you hanging on here. This will convert to a recording after some time, so you should be able to go back and see this as a recording and watch it. If you feel like this was beneficial, if you feel like it was helpful, if you could eliminate the technology issues, please let us know. We'll consider doing more in the future, and we'll figure out the tech problems before then. But we will, again, we appreciate you jumping on here and for the support. I know we had issues with Slido. And part of that was because of me trying to fix a tech issue, which never really got resolved. So all of that was really a tech issue on our part. This was our first time going live on YouTube, but we'll dive into that and figure out what we can do better and to make it worth your all's while. So if you have any questions, feel free to put them in the chat. I'm happy to answer them. And again, if you feel like this was beneficial and you'd like to see this on cardiology or medical or trauma or whatever it may be, let us know that as well so that we can get something planned and actually do it the right way so that you're not distracted by the a continuum of technology problems. But yes, this should record and post to YouTube, but we'll make sure that it gets, we'll make sure that happens. All right. Well, I'm not seeing any questions right now. I'll give it another minute or two. And then I will shut down the stream for tonight. Again, thank you all. Remember, if you are interested, we do have a code specific for you guys tonight. If you use the word alveoli, that'll get you 25% off of any of our study guides or our review courses. It will expire by this time tomorrow evening. So keep that in mind if you do want to use it. So again, that word was alveoli, and that takes 25% off any of our study guides or review courses. And if you do want to see, if you do want to go through this again and us do cardiology next, put that in the chat. And again, we will make sure the technology issues we face tonight are fixed before that. All right. Well, I'm not seeing any questions come through, so I appreciate it. Thank you all for jumping on and bearing with us, bearing with me. And hopefully we get to do this again in the future. And thanks for following along and your support. And if you have any questions in the meantime, feel free to reach out to us through social media or email, and we'll do our best to get those answered. But otherwise, have a good night. Have a good day tomorrow, and we will talk to you soon.